Hello, welcome back to Pharma Training Solutions. Today I will be discussing endocrine system pharmacology, the hypothalamus and the posterior pituitary and the anterior gland. Of course, we are meaning the drugs and the corresponding analogues. Let's first talk about the endocrine system, because the endocrine system controls and regulates a complex body activities, such as metabolism, growth and development, reproduction, and all those. And of course, this is through secreting hormones, either into blood by the ducted glands, of course we know these ones, or through the ductless glands. Now, I'm sure we are aware of the negative and positive feedback mechanism of these hormones, which regulates their own secretion. So, how do hormones cause their effects? Of course, they act via predominantly the nuclear receptors to modulate transcription of genes in the target cell. Of course, this is mostly the JAK or the STAT cytokine receptor, also referred to as the genus kinase or the signal transducer and activator of transcription receptor. Once this receptor is activated, transcription genes are activated, and they lead to formation of materials which are required in growth and development and all these. Can also act via the membrane receptors to exert their rapid effects via transduction pathways. Now, post these effects I've talked about them above, they control growth and development, they regulate energy production, storage, responses to stress. Here, of course, mostly through the cortisol enzyme, the cortisol hormone. There is also feed rotation, the aldosterone, which I'll look at it later on. Let's look at, of course, once hormones have served their purpose, they are metabolized and excreted. And they always have a short duration of action. That's why we have the analogues, which have been improved. Now, in the hypothalamus hormone, let's look at the hypothalamus hormone. Of course, these are secreted via the hypothalamic neurons, and most of them are either releasing or inhibiting hormones, and most of them stimulate the release of certain other hormones via the anterior pituitary gland. Now, let us look at those hypothalamic hormones. We have the growth hormone releasing hormone, of course, stimulates the release of growth hormone. The gonadotropin releasing hormone stimulates the release of luteinizing hormone and follicle stimulating hormone. Corticotropin releasing hormone stimulates the release of adrenocorticotropic hormone, and the thyrotropin releasing hormone stimulates the release of thyroid stimulating hormone. Now, dopamine is the only inhibiting dopamine inhibits the release of prolactin from the pituitary. Then I will explain all this on later. We also have oxytocin and vasopressin, which are produced in the hypothalamus, but they are stored in the posterior pituitary gland. Let's look at some of the analogues of, not all but a few, of these hypothalamic hormones. We have the gonadotropin releasing hormone analogues. Example, we have gonadorelin, and others include goserelin and hystrelin. Now, both zones are administered by IM and subcutaneous, and they stimulate the gonadotroph cell to produce or release luteinizing hormone or follicle stimulating hormone. Now, we also have the antagonist of this hormone. Of course, we have the antagonist. In case you have ovarian hyperstimulation, there are some antagonists which can be given to you. Ganirelix or cetrorelix, and others can be used to suppress the release of the gonadotropin production within the hypothalamus. Let's go to the anterior pituitary gland. Of course, it's connected to the hypothalamus. As I have said, most of the hormones of the hypothalamus, they stimulate other hormones within the release of other hormones within the pituitary gland, posterior pituitary gland, so the anterior pituitary gland. Now, which are those hormones The growth hormone, of course, the mediator of this one is insulin-like growth factor. I hope you know what this one is. We also have prolactin, because for injection of milk. Luteinizing hormone and follicle stimulating hormone. This one, of course, they can stimulate estrogen, progesterones, and testosterone in men. We have the adrenocortical hormone, stimulate the release of what? Cortisol, so mostly in stress. We also have the thyroid stimulating hormone, stimulate the release of thyroxine or triiodothyronine. Now this is what we call the T3 and the T4. Let's look at the growth hormone and the analogues of growth hormone. Now growth hormone we know is required during childhood, in growth and also in adolescence to attain normal size, and has effects on the lipid and carbohydrate metabolism. Now the analog of growth hormone is somatotropin. Of course, this is the analog of the synthetic product, a recombinant hormone. It's given by subcutaneous, and as I said earlier, it binds to the JAK STAT cytokine receptor activating insulin growth factor. Now, because this one, it has effects on carbohydrate metabolism, protein, lipid produced in the liver, and even other body parts, the bones, the kidney, the muscle. Remember, when it affects all these ones, it is leading to growth. These organs are increasing in size, and it is used in growth hormone deficiency, of course, in adolescents, and sometimes there are those adults who have lean body mass. Now, also have an insulin growth-like analog called mecasermine. Because some people may be the insulin growth-like factor may be deficient. Because even though you give now the somatotropin, it may not be causing an effect. So you need to give the IGF-1 factor. Now, also we have tumors in our pituitary, which can cause increased release of growth in a release of growth hormone, hence leading to abnormal bone growth. Remember, you're saying that growth hormone is required in all this bone growth, and it can lead to acromegaly or gigantism. Now we have the analogues. Okay, there is somatotropin. This is a hormone which controls growth hormone release, but has a short half-life. But we also have synthetic analogues of somatostatin. We have octreotide, and lanreotide. These ones are the analogues of somatostatin. We have pegvisomant. Now this one acts on the growth hormone receptor. It blocks the effects of these receptors. So all these ones can be used. Now the side effects, I will not be talking about them much, and however you can contact us or you can refer to official books in case you want more information. Let's look at the gonadotropin, this follicle stimulating hormone, and the luteinizing hormone. Now, of course, we know that in men, they stimulate stimulate spermatogenesis, and luteinizing hormone stimulate testosterone synthesis. In women, these ones are required in the menstrual cycle, in the ovarian follicular development. Of course, and also they stimulate the steroid hormone synthesis, estrogen and progesterone, required in the menstrual cycle, which I will talk about later on. The luteinizing hormone, of course, is identical to the HCG produced in pregnancy, so you should be aware of. Now, hence, the follicle stimulating hormone, the luteinizing hormone, and the humanogonadotropic, the HCG hormone, are used in infertility or to stimulate spermatogenesis in men, and also to induce ovulation in women. Which are those analogues of these hormones? We have the menotropins, lutropin alpha, urofluoritropin, and the gonadotropin alpha. These ones could be used if people have deficiency of this hormone, or if they are infertile. Let us talk about prolactin hormone. Because prolactin, it regulates milk lactation or milk production. However, in the case of these Sometimes we have the adenomas, which cause hyperprolactinemia, which is associated with nipple milk discharge. Now, we have, as we saw earlier on, the dopamine produced in the hypothalamus inhibits prolactin release. Now, which means that if you have a dopamine 2 receptor antagonist, like bromocriptine, we can suppress the effects of prolactin. That's why there are some ladies who want to stop breastfeeding. When they come to the pharmacy, they ask for that tablet called bromocriptine, because it will suppress the effects of prolactin. Hence, it will inhibit milk production. Now, the side effects of bromocriptine include fatigue, lightheadedness. We shall look at bromocriptine later on in other presentations. Let us look at the posterior pituitary hormones and related drugs. Now, of course, as I said earlier, we have oxytocin and vasopressin. Of course, these ones are produced in the hypothalamus and they are stored in the posterior pituitary. We have the uterine stimulants, oxytocin, now, or the oxytocics. Now, what's the mechanism of action of oxytocin? All of us know that it increases uterine contraction, but how does it do it? It binds to the G-protein coupled receptors and activates the phosphoinositide calcium messenger system, leading to opening of the calcium channels, allowing entry of calcium channel ions in the uterine smooth muscle. And of course, when the calcium ions enter, we shall have contraction of uterine muscle. This is now the effect what we see. I'm sure you are aware of this G protein and the IP3, because it studied. We shall cover it again in pharmacodynamics, I'm sure. And it can also cause contraction of the myoepithelial cells in the mammary alveoli, leading to ejection of milk. Now, what are the therapeutic uses of oxytocin? Of course, it's used in induction and augmentation of labor, control postpartum hemorrhage when it is given by IM. However, when it is given by nasal spray, it can be used in milk-based milk injection. Now, side effects are uncommon, but examples can include uterine rupture, placenta abrasion, excessive water retention, and fetal distress. That's why oxytocin is not used in when the fetus is abnormally located within the womb. Now, the others which I will discuss later on, we have prostaglandins, the misoprostol, and also the EGOT alkaloids, the igometrin and igonovin. So I think we shall discuss them later on somewhere. Now, let us look at the uterine relaxants. We have atosiban. Atosiban is an antagonist of oxytocin receptor and used to suppress preterm labor. We also have, given by IV infusion, we have beta-2 receptor antagonist, salbutamol, relaxes uterine smooth muscle. We also have the fedipine, the calcium channel blocker, because we know as when you block calcium, you can also suppress preterm labor. Now, vasopressin, because we know vasopressin, this is an antidiuretic hormone. It binds and activates the G-protein coupled receptors, the V2 receptors in the renal tubules, which can increase water permeability and water reabsorption, antidiuretic. Also, we have the smopressin, selective V2 agonist used in diabetes, in speeders, and also it can be used at bedtime to decrease nocturnal urine. The antagonists, we have conivaptan and tolvaptan. So this has been a short presentation on introduction to endocrine pharmacology and pituitary and hypothalamic hormones. You can always refer to it, or you can refer to other presentations, or you can contact us for more information. These are the other presentations which we have in endocrine. Thank you very much. I always remain Wilson from M-Pharma Training Solutions. Leave a comment, subscribe to my channel in case you haven't subscribed, and thank you very much.